This is one of we do monthly webinars for MACS, and if people are new to MACS, it's the Maryland Addiction Consultation Service. We'll talk a little bit more about it, but again, for people unfamiliar with it, it's a partnership between University of Maryland School of Medicine and the State Behavioral Health Administration, and really it's a service that we've set up to try and help providers out there who don't do primarily addiction work be able to feel more comfortable doing addiction work. So we have a phone line that you can call in, kind of a warm line where you can ask questions either in general or about specific patients. We also have the website. You can actually email. I think we have other kind of social media that you can ask questions as well. So again, just in case people are not familiar with what MACS, the services it provides. And then we also try to reach out to different practices and kind of help them implement or work on practices that would, again, help them feel more ready to address substance abuse issues in their practice. So today's talk is we're going to focus on. I'm trying to get the
pull up the PowerPoint because that's just a screen. Click on it apparently. So you can just hit this. And you can click on the screen.
So we're just trying to get the technology. This is a new webinar technology we're using. So
Here, let me see. If you click this screen, then it'll flip.
click
This screen.
Got it. All right. So today we're going to talk about using medication-assisted treatment to treat opioid use disorders in the hospital. We decided to do this because it's a topic that a lot of people have questions about, and we're really doing here in Baltimore City. The health department is really encouraging all the hospitals to do more to treat opioid use disorder in the hospital. And I know a lot of the hospitals across the state are doing so as well. So it's we've really focused primarily on outpatient prior to this, and we're really want to expand and try and get people doing more in the hospitals as well. So just a little bit where we're going to cover some basic terminology, some basic epidemiology, just real quickly about the current opioid epidemic, a little bit of the history of treating opioid use disorder, because it's important to understand that, because some of the laws, especially that apply to treating opioid use disorder, it's really relevant for working with people in the hospital. We'll then talk about some of those laws, and then we'll talk a little bit about different aspects of treating people in different areas of the hospital. So first, just to talk a little bit about some of the terminology that is out there. And the reason I'm bringing this up is because all the time we keep hearing in the news, and you read studies, and the CDC, all different groups putting out information, and they just use all these different terms: addiction, dependence, use, misuse. So it's really important as you're trying to work with patients and work with others, especially in the hospital, where, again, a lot of the focus on treating opiate use disorder and addiction in general has been really in primary care settings. Hospitals have kind of been the last group to be really trying to do more with this. So it's important to understand that a lot of times people who work in the hospitals have not been kind of learning as much and had as much outreach as especially primary care clinics have over the last decade or so. So it's important to be able to talk to your colleagues and others, patients in the hospitals, about the different terminology that they're going to hear, and just to be able to understand the difference between addiction, use, dependence, and be able to help them understand if they're reading things, medical articles or things in the popular press about this, that the terms are very confusing. Another big push is, and this is all across medicine, but really in the field of addiction as well, to try and address issues of stigma, is really to try and get away from using stigmatizing language. So there's a big push toward people talk about patient first. So talking about a patient with a substance use disorder, rather than a lot of these terms, which are, very commonly used. And people, even themselves in recovery, will say, I'm an addict. But again, we're really trying to get away from labeling people by their behavior and really focus on them being a person with a condition, a substance use disorder. Another term really trying to address is the calling people or calling their urine clean and dirty. This is obviously a joke, but it is true. And I think, as we as you're talking to people or seeing people or talking about them in the team room or whatever it is, it's just being careful with the language. And again, with the patients themselves, who, think of themselves differently depending on the language that is used to describe them. So just real few slides on the epidemiology and why this is such a big deal that we're talking about this. So if people were not familiar, recently the national numbers came out for 2017 as far as fatal overdoses. So you can see here over 74,000 total fatalities. Now this is all substances, including alcohol, but the vast majority are opioid related. You can see here, methadone, which in the past have been a problem, coming down. Heroin, which had significantly gone up from 2010, starting to level off the last year. But the big issue here, this blue line, is the synthetic opioids, and primarily that is synthetic fentanyl and different fentanyl analogs that have made it into the illicit, mixed with heroin or totally replacing heroin in the illicit opioid stream out there. The other thing that's concerning is we see over the last couple of years these increases, but significantly in 2017, involvement of cocaine with overdose, cocaine in combination with opioid. And so what seems to be happening, at least in some places, is that people who think they're buying only cocaine, so it's not even someone who typically uses opioids, some of these fentanyl analogs are being put in the cocaine. We're actually seeing it with marijuana and other drugs as well. But a big issue with cocaine, especially, that we're seeing across the country, also with methamphetamine, that it seems like it's being adulterated with some of these new synthetic opioid analogs. Here in Maryland, again, if people aren't familiar with our numbers, very similar, similar to the national, where we had heroin going up, and you see here actually in 17 came down. Prescription opioids really have kind of leveled off and come down a little bit. But fatalities, you see from 15 to 16 to 17, just still skyrocketing with, again, primarily the illicit fentanyl analogs that are being put in the heroin. And here, just to show you, it's pretty much every county in the state has had some fatalities related to, heroin, prescription opioids, and the synthetics. And as you see here, pretty similar. Baltimore County, Anne Arundel, PG. The more rural counties definitely have issues, and given their sizes, it's still can be a significant proportion, but a lot of it here and really in the central part of the state. We also, a lot of the press gets put on the fatalities, but real important to be aware of how many people who overdose end up not dying, but end up with significant medical issues. So you see here, this is both inpatient medical stays and emergency room visits significantly going up, and even from 2014 continue to go up. And here, we've talked about Maryland kind of leading. Unfortunately, we lead in these as well. So we've, number one and number two, as far as, per capita admissions and per capita emergency department visits related to opioids. So it's not just the fatalities. A lot of patients who overdose end up in the ICU for weeks or even longer, with hypoxic brain injuries, with rhabdomyolysis, with a lot of other medical conditions that really contribute to morbidity, but also cost of medical care. So important to talk about, why we're addressing this, and I think it's important to just mention, because I think a lot of people feel that people with addiction really don't change, and it's real important. And even if people who work in the hospital, unfortunately, you probably see people at their worst, and the people you see that repeat coming back in, having overdosed, having endocarditis, whatever it is, it's easy to kind of get the impression that most people don't change, because you rarely get to see the people who are being treated as outpatients and doing well. So again, it's important in the hospital especially to remind people that a lot of people with addiction really do well. They're able to change, and that they really do well with drug treatment, because a lot of people are not, that's not their experience. So as far as treating opioid use disorder, a lot of evidence that using medications is very helpful. If people are not aware, there are 3 medications approved in the US to treat opioid use disorder: methadone, buprenorphine, and naltrexone. We won't talk today about other experimental things that are used, some in other countries, but that also seem to have promise. So like I said, it's important to understand a little bit of the history of treating opiate use disorder, because we'll talk about the laws that apply to this that are very unique in medicine. But treating opiate use disorder goes back at least to the mid-1800s. And it's just something I find interesting. I'm not sure that we're going to be doing this here in Maryland, but when cocaine was isolated from the coca leaf back in the 1800s, a lot of people thought it was a good treatment for morphine addiction. Similarly, during that time, there were a lot of other cures coming out, sanitarium, other things. And, again, at this point, there was no regulation, there was no FDA or any kind of control over treatments. If people weren't aware, heroin was marketed in the late 1800s and primarily used to help with cough. This was, when TB was a huge problem. But there were also people that felt that heroin was less addicting and would be a good treatment for morphine addiction at the time. So as we'll start to talk about some of the laws, and we'll go through all these and how they relate to treating opiate use disorder in general, and then some of the specifics about how they relate to treating opiate use disorder in the hospital setting. So this was one of the first attempts to try and control use of opium and morphine to treat opiate use disorder. So if people haven't heard of the Harrison Narcotic Act of 1914, basically began the control and what later led to, here you see from the AMA, basically forbidding physicians to prescribe opioids to patients to treat their opiate use disorder. And back in the 1920s and 30s, were actually physicians jailed when they continued to prescribe people morphine to treat their morphine or their heroin addiction. So this is really what we saw back, 100 years ago, where the laws were put in place to really limit the physicians being able to prescribe opioids to treat opiate use disorder. And continued this way. There was, back in the 1930s, this was kind of a combination of a hospital jail and research facility where a lot of the people in the U.S. went when they had problems with, primarily, different drugs, but there was a lot there related to opiate use disorder. And it really continued to be primarily a criminal issue until this is from 1965, and this was the first paper published on using methadone to treat heroin addiction. And very soon after that, in 1970, is when we started using methadone in a clinic kind of setting, largely driven by the increasing heroin problem that we had in a lot of our big cities here in the U.S., as well as knowing that a lot of the soldiers in Vietnam were using heroin and opium. And as they were preparing to come back, President Nixon actually pulled together the team that put in place what became our treatment system using methadone and methadone clinics. So the Controlled Substance Act, put into place in 1970, was really the first attempt to kind of put controls on controlled substance prescribing. It's where we got the 5 schedules of drugs that we still have today. And it really defined who was able to prescribe somebody controlled substances. So these were the kind of the requirements. And luckily back then, at the time they were putting together the methadone regulations, they actually put in place some exceptions to the law of who can prescribe opioids. And we'll talk about how these relate in the hospital, but one of the exceptions that was put into the Controlled Substance Act allowed for what people now call the 3-day rule. So it allowed a physician to administer, and it's very important that it's administer and not prescribe and not even dispense. So the patient actually has to take the medication in front of the physician, but you're allowed to do that for up to 3 days as you're trying to manage somebody's withdrawal and you're trying to get them in more kind of ongoing treatment. So again, somebody has to go to a methadone clinic to get their methadone, but this exception was put in place to allow somebody to be able for 3 days to be able to get medication administered to them. And we'll talk about how this is being used now in emergency departments to start people on buprenorphine. The second exception to the Controlled Substance Act that was put in place then, some people call it the adjunct rule. So this allows that if somebody's admitted to a hospital for a reason other than specifically their opiate use disorder, so even though they could have endocarditis that is from injecting heroin, they're admitted for the endocarditis, not specifically for the opiate use disorder. So as long as someone's admitted to the hospital for some other reason, a hospital is allowed to give, and the law doesn't specify, so you can actually give any opioid to someone to help manage their withdrawal while they're in the hospital having their other condition treated. So this is generally used in acute care hospitals that are licensed with the DEA to dispense controlled substances. It becomes an issue that we'll talk a little bit more about later with subacute hospitals like nursing homes, where a lot of times patients will go for IV antibiotics. They're not licensed the same with the DEA, so they're actually not allowed to use this exception to the Controlled Substance Act. Just kind of filling out the law specifics. So this was kind of an outcropping of the Controlled Substance Act. The Narcotic Addict Treatment Act in 1974 really spelled out the regulations that go along with opiate use treatment in OTPs or methadone programs. So all the regulations around take homes, all of that, it was kind of spelled out in 1974 with that. It also just kind of reiterated the exception to the 1970 law, where you can start somebody on methadone in the hospital if you're treating something else, but it also allows, if somebody's already on a methadone clinic, it allows the hospital to continue them on their methadone while they're in the hospital, and dispense it from the hospital's pharmacy. Again, that's different when somebody goes to a subacute facility. If people aren't aware, when a patient goes there and they're already on a methadone clinic, the methadone clinic actually has to deliver their methadone for them to take at the subacute clinic. So, but again, the Narcotic Addict Treatment Act kind of reinforced the exceptions in the previous law. And then, I don't know how many people watching have their buprenorphine waiver, but the things pretty much stayed the same from the 1970s until 2000, where really the only way to get medication to treat your opiate use disorder was from a methadone clinic. There was some oral naltrexone being used, but mostly in methadone clinics. And then the Drug Abuse Treatment Act of 2000 allowed for any physician, as long as they do the required 8-hour training, to be able to write prescriptions for buprenorphine and allowed a pharmacy to dispense it, which again was not allowed under the previous 1970s law. And that law stayed in place. And again, if people weren't aware, the Data 2000 specified that it was only physicians who could do that. The CARA Act from 2016 allowed nurse practitioners and physicians' assistants to also be able to prescribe buprenorphine, and it also expanded the number of ultimate patients that after a couple years of doing buprenorphine treatment, that a clinician is allowed to request to be able to treat. So again, that was just a kind of review, because it's a very unique situation in medicine that we have these federal laws that dictate what we're allowed to do. Most things we do are based on best practices, but actually for treating opiate use disorder, these very specific federal laws that apply. So just a reminder, I'm hoping most people are aware of all this, but as we're talking about opioids, to distinguish full agonists, which heroin, morphine, methadone are. So they have a dose response that the more opiate you give, especially in a naive person, you get 100%, which the main toxicity being respiratory depression makes full opioid agonists all potentially lethal because of that respiratory suppression. So real important to keep in mind the pharmacology here of the full agonists, and that's as opposed to a partial agonist, which is what buprenorphine is. So at lower doses, buprenorphine acts primarily as a full agonist, but then it begins to have a lower activation of the receptor, and what's very different is that you have a ceiling effect at a much lower opioid receptor occupancy. So it makes it much, much harder for somebody to overdose, much less respiratory suppression. You can see, if you add a sedative like a benzodiazepine, you can get more, but partial agonists, because of this, are much safer because there's much, much less respiratory suppression. It also makes them less effective for pain management because you're not getting the full agonist effect. But a lot of people can do really well with a lot of pain from the agonist effect that you do get from a partial agonist. And then just a reminder of antagonists, as we're talking about naloxone or naltrexone, where you're getting binding at the receptor but no activation. So in case people aren't familiar, I just wanted to show and remind people the different formulations of methadone. And it's important to be able to know about this and talk to patients, because most methadone clinics use a liquid form of methadone, and the nurses add water, and then the patient drinks it at the window. And then when they get take-homes, they get little bottles that have the liquid in it. There are some programs that actually use these 40 milligram tablets, But most patients and most programs are going to be used to the liquid. Many hospitals actually don't carry the liquid formulation. They usually will have the 5 and 10 milligram methadone tablets that are used primarily for pain. So, again, when you have a patient who's hospitalized and they're used to 100 milligrams a day of the liquid, sometimes it's hard for them to realize that these 10 little pills that they're taking are the same thing. So just to remind everyone of that. Also to be aware that there is a parenteral formulation of methadone, which tends to be about twice as potent. So for generally, if someone's on 100 milligrams, say, of oral methadone, you would want to cut that dose in half if they were to get parenteral methadone. Sometimes we have people admitted and they're unable to take anything orally, or so sometimes they'll get put on parenteral methadone. And similarly, we have now a bunch of different buprenorphine and buprenorphine naloxone combination products out there. And they're the kind of traditional Suboxone film. There are now a bunch of different buprenorphine and buprenorphine naloxone generic tablets. There are the Bunavail, which is a little strip that actually has an adhesive that you stick on the inside of the cheek. Zubsolv, which is a different tablet. There's now, people aren't aware, there's actually an implant that's sewn under the skin. Earlier this year, Sublocade came out, which is a monthly injection of buprenorphine. And then there are also the formulations that are approved for pain management. So the Butrans patch, the Belbuca, they're very low dose buprenorphine tablets. And then actually in the hospital, sometimes we'll see a parenteral formulation of buprenorphine called Buprenex, which is also approved for pain management. So it's just important, again, similar to methadone, a patient may take the film as an outpatient, but when they come in the hospital, most hospitals, if they even have buprenorphine at all, they're not going to have all the various formulations. So a patient may need to go on the generic buprenorphine tablet in the hospital when they're used to taking the film as an outpatient. So now we're just going to talk a little bit about managing opioid use disorder in different areas of the hospital, and some examples we'll go through. So the general kind of medical surgical patients, real important to try and screen everyone, because a lot of times that's a real barrier to even identifying that somebody has a problem, is that a hospital may not have a good system in place. Trying to identify opiate withdrawal. So if people aren't aware, probably the most used scale is the clinical opioid withdrawal scale. There are other ones used as well, as opposed to an outpatient program where most patients coming in and they're just in withdrawal. What often complicates things in the hospital setting is that a lot of the patients are also in pain, and trying to figure out which one are you managing, the pain or the withdrawal. Giving somebody an opioid should, in theory, help with both, but a lot of patients feel that the short-acting opioids are to treat their pain, and even though they're on a significant dose of opioid that's helping their pain, they'll still complain of being in withdrawal. So in the hospital, it actually can be more complicated. Trying to use the CAL scale to treat somebody when they have significant pain isn't also going to be adequate, because you're only really addressing the signs and symptoms of their withdrawal and not their pain. So again, things can just be a little bit more complicated when somebody's hospitalized, when you're dealing with both opioid withdrawal and pain. As you're talking with somebody about how you want to manage their withdrawal, because we have such strong evidence that medication-assisted treatment is really the most effective treatment, we're generally not looking to put somebody on an opioid to taper them and detox them. We're actually looking to get them started on a maintenance course of medication. So it's important to be able to talk to patients about that, to explain to them that that really is where the evidence is strongest, that people do best, and it also helps reduce overdose more. But it's also important to talk to patients about their preference for medication. So methadone versus buprenorphine versus naltrexone, and we'll talk about some of the pros and cons of each. As far as potential adverse effects, methadone tends to have more. There's QTC prolongation that you can see with methadone that you don't see with the others. Much more significant drug-drug interactions with methadone than you see with buprenorphine. Other effects on things like sleep apnea, much more significant with methadone than other treatments. So sometimes there are other medical reasons where one medication may be more favorable. And then you also want to be aware of what the availability is for follow-up. So somebody might want to get on a methadone program, but if they live in in an area of the state where the nearest methadone clinic is an hour away, that may not be the best option, because the law requires that they go to the methadone clinic. Generally, it's 6 days a week. So again, you need to also be aware of what the availability for follow-up is. If somebody wants to be on buprenorphine, but there aren't very many providers, or a provider that only takes private insurance and not medical assistance, so all of those things are just as important as the medical reasons as far as which medication you may choose to start somebody on. And just here, there isn't a lot of research, but we'll talk about some of what's out there. But in general, what's shown is that if we try to really aggressively manage somebody's opioid use disorder in the hospital, it really cuts down on AMA discharges and increases the chances of them engaging in treatment when they get out of the hospital. This is just one example of a study that was done actually out of Union Memorial Hospital, where they followed people that they had started on Suboxone in the hospital. And just, briefly, but they found out that, and this was just really not a controlled trial, but they were just trying to see how, what they had implemented at the hospital, how much it helped. And, it saw significant decreases in people coming back to the ED and repeat hospitalizations. So, and again, this has not been widely studied, but most of what has been done with hospitalized patients has shown similar results. Just a little bit on pain management for admitted patients. And again, none of this is really in stone, and there are people now looking at buprenorphine as a primary pain management. But if somebody comes in and they're either on buprenorphine or they would really like to be on buprenorphine, you can start them on short-acting opioids. Sometimes, if somebody's already on buprenorphine, you can raise the dose and split it to 3 times a day, or sometimes even 4, and get better analgesia. Similar with methadone. A lot of people take methadone or even buprenorphine once a day, and it helps them not have withdrawal for 24 hours. But when you're also trying to manage pain with it, it often needs to be dosed at least every 8, and sometimes even more often. If somebody's going to get on methadone, you can start the methadone and then continue short-acting opioids on top of it to help manage their pain. Methadone, again, can be used for pain and generally has to be split to 3 times a day as well. It's just important, if you're doing this and using the methadone also to manage pain in the hospital, to remember that when the patient gets out of the hospital and goes to a methadone clinic, they're no longer going to be able to get it 3 times a day. They'll only get it once a day. So in general, if you're going to do that, you want to have the person on a once-a-day dose for at least a few days before they leave the hospital, to see what other kinds of short-acting opioids they may need on top of the methadone to help manage their pain. And just a little bit more on buprenorphine and pain. So again, you can use it in the hospital. you can use any formulation because that Controlled Substance Act exception doesn't specify, that was written before buprenorphine was even synthesized, but we generally, use buprenorphine and fit it in with the other opioids there. On an outpatient basis, though, it's important to remember that the formulations that are FDA approved for treating opioid use disorder, like Suboxone, Zubsolv, they can be used off label to treat pain. And you don't even have to have your Suboxone waiver to do that. But the FDA approved medications like the patch and the Buprenex, they cannot be used to treat opioid use disorder because the Data 2000 law very clearly specifies it only can be done with things that are FDA approved for treating opioid use disorder. So even though it might make sense, and there are people looking at using the Butrans patch to treat opioid use disorder in an experimental way, right now that actually the law does not allow somebody to do that clinically. So here's just one case of somebody in the hospital. This is a 28-year-old female with history of opioid use disorder and cocaine use disorder with chest pain, fever, and chills. She mixes speedballs, $100 of each for 4 to 5 years. Has very little abstinence and has significant withdrawal when she tries to stop using. And she had literally used just prior to coming into the hospital. She found to have bacterial endocarditis and is being admitted to the hospital for 6 weeks of IV antibiotics. Unlike most people who don't use IV drugs, if you needed IV antibiotics, you get a line and go home with visiting nursing, and your spouse or whoever would help you with your IV antibiotics. Most places aren't going to allow IV drug users to do that. So most of the time, if they need extended IV antibiotics, they're going to go to a subacute nursing facility. So people aren't familiar with them. But as I mentioned earlier, because of their being licensed differently with the Drug Enforcement Administration, they are not allowed to use that adjunct exception. So they're not allowed to continue to give people, say, methadone. If you started someone on methadone in the acute care hospital, the SNFs are not allowed to continue somebody on that. The only way that they can get methadone is if they're on it 3 times a day for pain. And even then, some of them won't take people on methadone, even though it's written for pain. If somebody's already on a methadone clinic and they go from an acute care hospital to a subacute, then that patient's methadone clinic needs to deliver the methadone to the subacute nursing facility. So again, just to highlight that if somebody needs to go to a subacute nursing facility, it gets complicated as far as trying to manage their opiate use disorder. A second vignette with a 54-year-old female admitted for pneumonia, no other significant medical history. She reports having been on methadone 40 milligrams a day for past 3 years and receives 13 take-homes because she'd been doing very well. The clinic was, and this is actually a real case too, I had a number of years ago here at University of Maryland. The clinic was called, confirmed that that's what she took. Everyone was told how well she was doing. So the medical team just started her back on her 40 milligrams of methadone. The following day, the patient was sedated, slow respiration, constricted pupils. So they called me to come and talk to the patient, find out why that would be going on. And turned out that this patient was on 40 milligrams of methadone a day and getting 13 take-homes for 2 weeks, but she actually would only use a couple of the take-homes a week, and she was actually storing all of it. She wasn't selling it. She started describing to me how much she had, and I was concerned enough that I didn't want her to try and dispose of it on her own. So I actually went to her house, and this is what she had. I calculated it was over 20,000 milligrams of methadone that I ended up flushing. But it's important to remember in the hospital, especially again because people aren't as used to working with people in methadone programs, that just because a patient, and I'm not trying to imply, I think the vast majority of people take their methadone correctly, but also you need to be cautious because there are some people who are not taking it correctly, and even though you confirm the dose with the hospital, you still want to just be careful as you're putting somebody on their methadone in case they're not really taking it as much as they say or their clinic thinks they're taking. As far as psychiatric hospitalization, really no distinction as long as somebody's admitted to the hospital for a reason. So most general psychiatric units, even though somebody's primary problem may be their substance use, they're generally going to be admitted for something else like depression. So that exception to the Controlled Substance Act allows you to also treat them in a similar way while they're in the hospital. A detoxification unit, like some of the hospitals like Bayview and Mercy Hospital have, those are different because there the patient is actually being admitted primarily for their substance use disorder. So that exception to the law actually doesn't apply to them. So it's actually harder for them to get somebody and maintain them on the opiate for longer than those 3 days that are allowed through the other exception. But again, it's real important, and if people aren't aware, the amount of comorbidity with other psychiatric issues and all addiction, but especially opioid use disorder, is extremely high. So really important, especially on psychiatric units, to be trying to address both the non-addiction and the addiction mental health problems. Just another example. This is a 57-year-old male, major depression and opioid use disorder after a suicide attempt, and which was pretty serious. The patient actually had some hypoxic brain injury, underwent ECT, and started on Suboxone, 12 milligrams a day. As the team was then trying to arrange aftercare, they found it difficult because a lot of the recovery houses would not take people on medication-assisted treatment, methadone, buprenorphine. A lot of places in the state still have this. I would say here in Baltimore, more of our recovery houses will take people on medication, but even some of them still won't. And I know a lot of other areas in the state, they definitely won't. So again, it can really affect how you're going to try and treat someone ultimately. Brings up the third medication, which sometimes in the hospital is something we can do. It's very hard to start somebody on naltrexone, the long-acting, the monthly injection Vivitrol, as an outpatient because somebody really has to be opioid-free for 5 to 7 days in order to get started on naltrexone. But sometimes somebody in the hospital may actually be there long enough that they can get off their opioids and get started on naltrexone. So we've here we've been able to do that with people both on medical floors and on the psychiatric floor if we're able to again help manage their withdrawal symptoms with non-opioids long enough that we can get them started on naltrexone. Many places that do not allow people to be on an agonist or a partial agonist like methadone or buprenorphine will allow people to be on Vivitrol and get that monthly shot. So again, for some patients, it's an option that you might be able to use. There's another case, patient with schizophrenia, also using heroin. They're actually on a methadone program on 100 milligrams a day, and they're on quetiapine, but because of their worsening symptoms, you raise their quetiapine from 300 to 600 milligrams a night. The patient starts having lightheadedness, palpitations, syncope. You do a EKG, and their QTc is 610 milliseconds. So just to highlight, an issue with methadone, especially that it can prolong QT. Something else that you can do more easily in the hospital than you can do as an outpatient is switch people from methadone to buprenorphine. It's very difficult because generally they have to be off the methadone for at least 72 and often, even longer, at least 3 to 4 days. But in the hospital, because of that one exception to the Controlled Substance Act, you could actually switch somebody from methadone to a short-acting opioid like oxycodone or morphine, keep them on that for 4, 5, 6 days, depending how long they're going to be in the hospital, and then switch them from the short-acting opioid to buprenorphine. Again, that's a lot harder to do as an outpatient because you're not allowed as an outpatient to do that. You can dispense a short-acting opioid for those 3 days, but it's a lot harder to do that. So again, using the opportunity sometimes in the hospital, if somebody's having some complications from their methadone, especially around QT prolongation, if they're going to be there long enough, you might be able to use that to your advantage to help switch them to buprenorphine. Moving to the emergency department. So a lot of places now are doing SBIRT in their emergency departments. Here in Baltimore City, and now a lot of the hospitals in the state are using peer recovery coaches in the emergency department, helping implement their SBIRT. But what a lot of studies have shown is just doing SBIRT alone doesn't seem to be very effective. So just talking to somebody about their drug use for 5 minutes in and of itself isn't as effective as SBIRT seems more effective with problematic alcohol use, tobacco use. For drugs, it probably has to be more than that. So we'll talk a little bit about studies looking at starting people on medication in the emergency department, primarily buprenorphine. And it does seem that really helps with engagement and people following up with an outpatient treatment, and affecting rehospitalizations. I put here that there are several models, and we'll talk about that. So one model is where the emergency room physicians actually get their buprenorphine waiver, and they're allowed to write somebody a prescription that they can then get filled and take the Suboxone after they leave the emergency department. Another model, which is what we've done primarily here in Baltimore City, is using that 3-day rule, and dosing people in the emergency department. And again, you're allowed to administer them any opioids, so you can administer buprenorphine to get them started, and then having arrangements with other providers to take patients the next day onto buprenorphine and get them, on a more of a maintenance track. So you can either have your doctors get their waivers, you can have administration of buprenorphine in the ED, and then the third is actually where you have people either follow up, as I mentioned, with outside providers, or what some places are doing is actually having people come back either to the ED the same way they would maybe for a wound check, or to get like the second injection for rabies vaccine. Or other places have a kind of a bridge clinic set up within their hospital that the patients return to as they're awaiting a spot in in a more ongoing treatment program. So just understand that there are different ways that it can be done starting in an emergency department. The biggest study, there are a few underway now, but the one that really kind of got people doing this was done out of Yale. It's published in JAMA a few years ago. So there they divided people into 3 groups. So they either started them on buprenorphine with a 3-day prescription. So again, their ED docs had their buprenorphine waivers. They had another group that just got a brief intervention, but a facilitated referral to drug treatment. So kind of a warm handoff to our program, but not receiving buprenorphine. And then a third group that just got, here's some phone numbers and, you're on your own. So you can see here that they had significantly better, they looked at engagement at 30 days in the program, significantly better with the buprenorphine group. illicit opiate use was significantly better, and then looking at urine toxicology. So again, a lot of places after Yale had done that have started doing this. Um, Here's just some of the numbers from here in Baltimore City that I had just pulled. This was from when the first hospital in the city started back in February 2017 through um, April 2018. Now all of the hospitals in the city are doing it, but initially these 7. So you see here kind of some of these this was a brand new thing for them. So, but seeing at least 50 to 70, 80% patients who followed up with the outpatient treatment, which again is going to be a lot higher than if you don't start people on the medications. And as I said here, we're seeing here in Baltimore City, I know a lot of the other hospitals in other counties in the state are doing it. And just to show you kind of, Massachusetts, New York, California, a lot of other places now across the country are starting to do this as well. Just to kind of finish up, I'm going to throw out something controversial that there's talk of this in the news, but we're not going to see this probably for a while in the U.S. But Canada and a number of European countries have safe consumption facilities where people actually go to use their drugs in a much safer way, and been shown to significantly cut down on overdoses and needle-related toxicity like endocarditis, abscesses. But there are also some of these now cropping up in hospitals. So there's some in Europe now. In Edmonton, Canada, had started doing this, where they actually have these rooms physically in the hospital to again help just come up with other ways to help deal with this population of IV opioid users. And just, I already mentioned this, but to really emphasize that, here in Baltimore City, they're kind of following what Rhode Island did, where they had all of their hospitals be kind of certified at different levels of how well they deal with opiate use disorder. So it has to do with doing things in your emergency department, then doing things with patients once they're admitted, and then actually with your outpatient clinics as well, and being able to start people on medications, making sure they have naloxone, all these different things that Rhode Island did, Baltimore City did. The hospitals here in the city are just now kind of doing their certification that's going to be announced in a couple weeks. And I know that, again, a number of the hospitals across the state are starting to do something like this. So again, why we're kind of talking about this. Also real important that this has become a big emphasis of medical education. So medical schools are starting to do more. Residencies are trying to do more with this. So people who work in hospitals that have students in residence, it's becoming a bigger piece of their training. So, we have some time for some questions. And then, again, just a reminder as far as Max, which, again, when we started this a little over a year ago, is really to reach out to primarily primary care physicians to help them feel more comfortable. And when we started, it was really focused on those using buprenorphine and trying to help them feel more comfortable. And over the last year, we've really expanded to all opioid use disorders, and then really now all substance use disorders in general. And we're now kind of, really there had been a focus on outpatient, but now recognizing that a lot of hospitals are also trying to do more. We want to make sure people are aware that, that our Maryland Addiction Consultation Service is another resource for helping with helping you and your facility, if people are working in hospitals, figure out how you can be doing more to help these patients. So I'm not sure how we do questions. I guess people can put them into the chat. Let's see, people have asked about the PowerPoint, which I think is going to be on our website. Any other questions about this? Okay. Well, like I said, the whole point of Max is if you have questions down the road, feel free to call us. You can go through the website. You can now, what do we have? Instant messaging, Facebook.
Twitter.
I don't do any social media, so, but I'm told that you can Facebook and Twitter and
Instagram.
any way you want to ask us questions, we will. Somebody that knows social media more than I do will help you. So, so again, if there are no other questions now, thank you, and hopefully everyone learned something, and hopefully you'll use the services that Max offers.